Thank you very much, Dr. Ismail and Professor Maria, for excellent lectures. My question is really maybe for both of you. It's regarding where to do these patients. You mentioned both that they should be done, the high-risk ones should be done in specialized pediatric centers. Is this related to the presence of a pediatric ICU, or is it the pediatric cardiac anesthetist? Because we do face this problem here in Kuwait, that we don't actually have sick kids hospital that have specialized pediatric cardiac anesthetist. But we have some general hospitals that have pediatric ICU. For example, in Adan, we have pediatric ICU, and so we have the backup. But does that mean that we can do the high-risk patients in Adan hospital? And if we don't actually have the option to send them to a pediatric anesthetist. So what's the best option for these patients?
If I may answer this, actually, because Dr. Maria, I think it's easier way in Texas than it is with our situation here. It's, the issue is not having just the ICU per se. It's the knowledge and the skill, both. I mean, the knowledge comes in different people with their expertise of their backgrounds and training, as well as the skills of taking care of such patient. Pediatric cardiac anesthesia is, how you say it, a rare commodity, I think, worldwide. I mean, it's not just here in Kuwait. I mean, in the States, you have these highly specialized children's hospital, which we don't have actually here. So the question comes, the importance of having a children's hospital, per se, and, what children's hospital will have in between its wings, all specialties. I mean, these patients can be actually, from their categorization, the risk stratification that was actually mentioned by Dr. Maria, and I had it earlier from a different study. A patient who's at one stage is a low risk can actually go into a high risk on this, on the table. He can change his stratification on the same day of the surgery. So, for those patients, I mean, if you don't have the pediatric cardiologist available on site or easily accessible to answer some of the questions, because he would be answering more than anything else, whether through a knowledge base or doing an investigation for you, echo or something, and then the anesthetist who's doing the work there during the surgery, and the intensivist who's later on caring for the patient post-operatively. So you need them all. I mean, if you don't have them, these patients, especially the high risk or the moderate risk, intermediate risk patients, you can lose them just in a few minutes. Simply in few minutes, they can, just die. And it will be difficult to retrieve them. So the issue is not just having a pediatric intensive care unit. So PICU will care for these patients post-operatively. NICU will care for them post-operatively. But what about? I will just mention a simple example. Dr. Salah is not here. I don't know, he left. Dr. Salah Taqi. Just a couple of days ago, a patient was born with tracheoesophageal fistula, esophageal atresia, and these patients, as some of us know, Dr. Maria knows, you have to operate them so quickly. I mean, you can't just wait. They have, a fistula from the lungs going to the guts, and the patient. Sorry. They are so difficult. So you have to operate, and the patient had a large defect, and he had severe pulmonary hypertension. So even children, when they come, they don't read the book. So they don't come with one thing, with one entity. They can have combination of things. So this patient was born in a private hospital, which is even, with all due respect, would be less than a district hospital level of care. And, was requested to be transferred to the only pediatric surgical, which is in Messina, but it was difficult. So was transferred to another local district hospital, which is the KOC in that situation, where we have a pediatric surgeon. And they, people worked on actually having some compromise, because the patient needs to be done. And it's easy to lose the patient. Patient did very well, had the surgery and everything, is almost being for extubation today. But things can go wrong, okay? We sometimes work with what we have, but it's not ideal in this part of the world. At least, if I may say, and everybody knows it as a fact when it comes to pediatrics, it's less than optimal. because most of all, we lack children's hospital where these patients should be in, because anything can go wrong. Simple stuff can go wrong and patient is lost. So I know it's a long answer, but it's my sad feeling not to have a children's hospital. It's especially when you go and train and work in children's hospital, and then you come back and there is no children's hospital. Dr. Maria, if you want to add.
Yeah, so I just have a question myself. Where are the children's operated, the cardiac lesion? You have a chest hospital or? And
we have the chest hospital, and they do the pediatric surgery there, the cardiac pediatric surgery, and we have Ibn Sina that does the pediatric surgery for other specialities, but things like dental procedures, endoscopies, we tend to do them and emergencies, yes, we do them in general hospitals, like Adan Hospital, Amir Hospital, and Jahra. So we do deal with these patients, but we do have often these problems that when we have the high-risk patient, we don't have the facility to send them to the Ibn Sina, because you don't have a dental list, do you, in Ibn Sina? So they have to be done in Adan Hospital. So we ended up having the experience in dealing with these patients, but the question is, ideally we should have a sick kids hospital, but we don't. What do we do meanwhile? How can we improve our facilities? Shall we get a pediatric cardiologist in our hospital? Yes. Pediatric anesthetist, yeah. We don't have people that are subspecialized, but we have people that have the experience in dealing with very young children.
At least I think the contact should be established with the treating. If they have cardiac disease, they have a pediatric cardiologist, right, following them. So that would be the first step. Ideally, yes, there should be a place where the children are taken care of. Because, it's not only, it's a team, it's the team that's important. It's not one ICU or one pediatric anesthesiologist. Even if you would transplant that pediatric anesthesiologist in an environment where he normally doesn't work, that's already some risk factor in itself. Even though he has the skills, he would have the skills in his facility, he may be lost in another facility, So I think it's a team approach, and maybe that's something to think about, how, as there are more and more of these patients, there's something to think about how you change the infrastructure here to make that happen.
In the meantime, while waiting for the children's hospital to be established, would it be a good idea to create a mobile anesthetic unit to anesthetize patients which are high-risk cardiac patients for non-cardiac surgery? Because I work in an orthopedic hospital and we are facing a pediatric patient with the complex cardiac lesions. I do believe the spine unit, for example, they do that in Kuwait. They have a mobile spine unit which they go and operate different places. Why don't we have a mobile anesthetic unit which go and operate on this high-risk cardiac patients in non-cardiac hospitals?
Yeah, it's a good idea. Why not?
Thank you.
It's
very
an
much.
excellent. Yeah, and you need, it's like you are calling for an ECMO team that will be equivalent to that, but it's.
You need to remember, you need a 24/7 coverage then, and that's not easy to put in place. And so.
As I said, there's already a mobile, for example, vascular unit in Kuwait, which they go operate for vascular surgery. We have a mobile spine unit, which they go operate in spine cases in different hospitals in Kuwait. So I think at the meantime, while waiting for the children's hospital to be established, I think it's workable.
It remains a good idea. It's an excellent idea. It's just to implement. Just maybe if no further question, just a last wording again. Like Dr. Maria is saying, there is no harm to ask for help. It's a teamwork. Lots of these patients, again, our patients with congenital heart disease who are operated or not operated, they are surviving through, older ages. So when they can present at any moment for whatever reason, elective or emergency, most importantly, those for emergency situation. When you face such a patient, please ask. try to find out, a source where can actually be more informative regarding the condition of the patient and how to approach him. And that will be actually very, valuable for the outcome per se. So asking for help always should be useful. Dictora.
Can I just add, because we are thinking of the surgeons, but we have to think more on the anesthesia and the nursing and the anesthesia technician and the post-operative care. This is not available yes, we have a pediatric ICU in our hospital, in Mubarak Hospital, but we are not the pediatric anesthetists, we are not the pediatric cardiologists. This is not a simple case. Spine surgeons, they are coming, we are doing adult spine cases. We're not doing pediatric spine cases. Vascular department are available in Mubarak, and we are doing almost whatever vascular cases can be done, but this is different. You cannot just bring the pediatric anesthetist, come on and work in an adult area, and the nurses and the technicians and all the instruments are not available. It's quite different. I cannot bring just have the same level, a spine surgeon to come and work and a pediatric surgeon to come and work in an adult hospital.
No, you're absolutely right. I mean, the concept of extrapolating thoughts like extrapolating dosage of medication for adults to pediatrics is totally not applicable. And extrapolating, applying, things like mobile units and whatever to pediatrics is also not right. It's a whole different world. It's a different concept. And that's what I said, initially, that having a children or a semi-children hospital facility would be the ideal. Unfortunately, we don't have that, and then we are going to lead our discussion into a vicious cycle, because you would say this and that. A simple nursing care makes a difference. A simple, the pediatric cardiologist will do a great job, the anesthesiologist will do a great job, the surgeon will do a great job, and then the nursing will lose the patient for us, possibly. Our nurses are great, I'm not saying that, but I'm saying as, thank you.
So I want to say that most of the patients who's coming in Abincina Hospital, they are not coming for general surgery. So we have many patients needs other specialty, not only cardiac. For example, last week we have one patient with tetralogy followed. He's coming with tracheomalacia, and we need anorectal malformation. Also, we need gastroenterologist. So this is combined surgery, plus you need post-operative care, you need neonatal ICU, and you need pediatrics ICU, you need cardiac ICU also. It's not easy. Thank you very much.
Okay. Thank you very much both to Professor Maria and Dr. Ismail Rida, and we'd like to call Dr. Ismail Rida, because he's going to leave us today at the end of this session, just to thank him for his contribution to the 7th Anesthesia and Critical Care Conference.